Good afternoon. I'd like to call the Hillsborough County Emergency Policy Group meeting to order. Will the clerk please call the roll?
Good afternoon. Miller?
Here.
Overman?
Here.
Merman?
Here.
Cronister?
Lazinski for Cronister.
Castor?
John Bennett for Mayor Castor.
Ross?
Here.
Lott? Snively?
Here.
And Ms. Wise?
Here.
Thank you. You have a quorum.
Thank you very much. We're now moving to public comment. The Emergency Policy Group, EPG, welcomes comments from citizens about any issue or concern. Your opinions are valued in terms of providing input to the EPG members. However, it is requested at the same time when you address the EPG that the comments are not directed personally against an EPG member, a staff member, or a presenter, but rather directed at the issues. This provides a mutual respect between the EPG members and the public. 20 minutes have been set aside for the public comment. Each speaker will have 2 minutes. First speaker is Jason Kimball.
Hey guys, so I don't understand what the difficulty is with removing the mask mandate. I've sent over the study on cloth masks. It's impossible to misconstrue it. It's very easy to comprehend. It explicitly said cloth masks significantly increase the risk of infection. So you guys are mandating something that increases the risk of infection. That's insane. That's outrageous. I mean, you're on record as being notified of this study and of this fact on Monday. So you guys knew on Monday. You guys still passed the mandatory mask requirement on Monday. This needs to be corrected today, immediately. And I mean, anybody who values their political career, I would think that you guys would want to correct this and get ahead of this, because the facts are going to come out. It's just that people don't know about this study, but they're going to learn about the study, and they're going to look and see who mandated this. Did they know about this study? And now we know you did. You knew about it on Monday. You know about it right now. So we're having a meeting now. So somebody needs to put forth a motion to remove the requirement for face coverings. It's dangerous. It's irresponsible. You're increasing the risk of infection. You guys are contributing to the COVID-19 numbers that you value so much. I know you guys don't care about fatality numbers, but new case numbers, you guys are contributing to that. So, I hope that we can just forget about the past, just move forward with the knowledge that we now have, and fix everything here, please. Thank you.
Staff, did Jeffrey Polisi sign in?
No, sir. That concludes public comment.
Okay, thank you. That concludes public comment. We're now moving to emergency management update. Mr. Dudley.
Good afternoon. Having some slight technical difficulties. Let's make sure you can see the slide deck here.
Mr. Dudley, what we see is a bigger. You want to show the storm update?
There you go. All right.
Okay.
You're up and running. I wanted to provide EPG a quick update on Tropical Storm Isaias. The center of the tropical storm developed a defined center of circulation overnight. With the 11 a.m. National Hurricane Center update, Tampa Bay is out of the cone, though the storm forecast may still shift. Tropical storm force winds extend outward up to 310 miles. There are currently no watches or warnings for Hillsborough County at this time. The storm center is about 1,000 miles southeast of Tampa and is moving northwest at 20 miles per hour with a maximum sustained wind speed of 60 miles per hour. Current forecast moves the center of Isaias across Hispaniola on Thursday and near the southeastern Bahamas by early Friday. The storm track is now forecasted to run just off the eastern edge of Florida with maximum winds up to 70 miles per hour. However, it is now less of a threat to Tampa Bay region. We can expect Enhanced rain potential and thunderstorm conditions may impact our region beginning Saturday and last into Monday. Tropical storm forecast may be possible in southern squall Saturday night through Sunday. About 1 to 2 inches of rain are possible, with possible higher localized amounts depending on the track of the system. Some localized flooding is possible Sunday into Monday, though those impacts will less if the storm track furthers to the east. We will continue to monitor river levels and update as conditions warrant. It remains too early to get specific storm surge estimates. The current NHS worst case model scenario suggests that from 1 to 4 feet of storm surge is possible. However, based on the current track, there should be little or no surge. Office of Emergency Management will continue to monitor. Some of the protective measures that we've been taking is we remain at an EOC activation level 2, partial activation. Currently, there are no executive orders from the state of Florida at this time. We're prepared for sandbag operations, fuel tanks being topped off, possible evacuation actions, including transportation and shelter operations, are being reviewed. Not expected to need that at this time. Because the potential for severe weather associated with the approaching tropical storm system, COVID testing at both state and county sites will be suspended at 5 p.m. today. All appointments will be rescheduled. When testing operations resume, all appointments will be honored at any of the state or county testing sites. We will continue to monitor the situation, collaborate with the state to open sites as quickly as possible. I ask that BOCC employees, partners, county residents should use this time to remaining to monitor the media, county message about storm for further development, review preparedness plans, restock disaster supplies, and for any additional needed information, you can visit hcfl.gov.net/stay safe for all current information. And you may also sign up for HCFL Alert to stay informed. And before I move to COVID site updates, I will take any questions.
Commissioner Overman, you recognize.
Thank you. And thank you, Mr. Dudley, for your preparation and all the work that you've done to get us ready for hurricane season. I know you guys are working really hard, especially in light of the pandemic. Ms. Beck, I have a question for you that pertains to this. The logistical question I have, should the EPG need to convene in the future regarding an coming storm, does the governor's order regarding the extension of the ability to meet virtually until September 1st apply to the EPG?
Yes, we will. At this time, we will still be able to, if we had to convene the members for an emergency meeting, we will still be able to do so for any required executive order.
Okay, I believe that answers my question. Thank you.
Okay, Mr. Dudley, I see no more questions concerning the tropical storm, so you're not going to move into the court report.
Okay. Today, as of today, last week we had 7,926 tests conducted last week. We're over 80,000 total tested. At this point, this week we have 4,584 tests conducted. We had 6,459 folks in the queue. As I mentioned earlier, we will honor anyone not being able to receive their testing today. We will reschedule and honor all of those reservations just as soon as it's safe to open up those sites. We will continue to collaborate with the state to ensure that we can safely open those sites. Logistically, we have 17 guests at the isolation site. We continue to distribute PPE as required for supported ALFs and nursing homes for those with critical needs. We'll continue to monitor their needs to ensure that they have everything they need throughout this event and this immediate event. This concludes my update. Any questions?
Commissioner Merman, you recognize.
Thank you, Mr. Chair. Just a quick question, Tim. Okay, so you're going to reschedule these appointments till Tuesday. Is that correct?
That's correct.
Okay, so if somebody has symptoms, I mean, when you call to reschedule these people, if they have symptoms, where are you going to tell them to go to the emergency room, or we're just going to ask them to wait another 6 days, or what are we going to do?
So the recommendation is at any time, if you're feeling that ill, where you feel that you cannot wait, it's advised to seek medical attention from your medical provider. Also, you can visit our website, and we do have those alternate means of receiving testing that could be available.
Okay, I just wanted to make sure that we have Plan B laid out for people in case, they're feeling ill.
Yes, and just as soon as we can get that information for the state, we're committed to opening these sites right back up as quickly as possible.
Awesome, thank you.
Okay, Mr. Dudley, thank you very much.
Thank
Appreciate
you.
it. Dr. Holt, public health update.
Yes, hello. This is Dr. Doug Holt, Florida Department of Health, Hillsborough County. Today, I'll review the epidemiologic and hospital data. As usual, I'll provide a high-level overview, and then Mr. Wagner will review the details. Afterwards, I will provide an update on our public health capabilities, our testing, contact tracing, and our healthcare surge that we will have and expand as we move forward to continue the efforts to control and minimize the impact of COVID-19. Kevin, Mr. Wagner, would you please put up the slide?
Go ahead, sir.
Okay, second one, please. We did add 467 cases today, so we now have 28,738 total cases reported. This represents 2% of the total population that have tested positive and are confirmed cases. The percentage of the total population that have died from COVID is 0.023%. This represents 328 preventable deaths. The estimated number of recovered individuals has increased again significantly as we predicted. It's now over 10,000. Again, is based on having a positive test and not being reported as dying 30 days later. Let's look at our trajectories. Our 14-day case, the daily average is now 518, and this represents a nice decrease and sustained of 17%. Looking a little closer, our 7-day average, this is 482 on a daily average for those 7 days. That decrease is slowing a bit, so we'll have to keep an eye on it. This translates into a rate of 241 cases per 100,000 for the last 7 days. Essentially, that's unchanged from the past 2 weeks. This is fairly similar across the Tampa Bay area. Pasco has the lowest with 150 per 100,000. Manatee is the highest at 275, and Pinellas is at 165 cases per 100,000 for those 7 days. Our tests, again, remain relatively high, even though the level is below a stretch goal that we set of 6,750, which we will continue to strive to achieve. Our positivity rate, 14 days, is now 13.22%. And this is an encouraging decrease. And my calculations on the 7-day, we are just above 10.5%. So my summary, we continue to see widespread and high level of COVID transmission. Our 14-day trajectory of cases is decreasing. The last 7 days has slowed, and we are encouragingly, our positivity rate is approaching getting under the 10%. Next slide, please.
Dr. Holt, let me ask you a question, please.
Yes,
If you don't mind. This is Commissioner Miller. You said today we had an increase of 467, but for the last couple of days, the Microsoft BI Power information we get is always a day behind. Like today it came out at 131, but it had yesterday's figures. Why is that? You know?
I'm going to answer that one, Commissioner, if that's okay.
Yes, sir.
So the FDOH update that occurred today was as of 7/29. So the data that's always presented by FDOH is always as the last day before, last completed day. So from a process standpoint, we, from an updating standpoint, don't know the number of cases that occurred on 7/30. They were updated on the last completed full day on a 24-hour cycle on 7/29, which was 400 something. Dr. Holt, because he's FDOH, may have more up-to-date information, but from an automated process, it's always going to be a day behind because I can't.
That I understand. I understand that. But today's date information that we received today was the same information we received yesterday at 4:44.
Sure. Okay. The other part of that conversation is when FDOH, we scheduled the Power BI to update or send out that email at 1:30 every day. If FDOH hasn't updated by 1:30, it's going to show the same number, if that makes sense.
So how does Miami-Dade get theirs faster than we do? Because
that I can't answer. Yeah,
because every day Miami-Dade gets the same figures, but they have their daily update. Instead, we have a day behind. For instance, like I said, today's is the 30th, and this is dated the 28th. And I'm just trying to figure out what's going on.
Right. That example of the 28th, that's correct. When we pushed the FDOH didn't push an update to their servers, lack of a better term, by 1:30. So what you've seen before, you've seen two in one day, one that's come at 1:30 and a second one that I've manually pushed after there's been an update by the FDOH. That occurred Sunday. I pushed one at like 3 o'clock because that FDOH timing doesn't always occur from an update standpoint by 1:30. That's the downfall of automation. If FDOH, who is the source data, doesn't update their servers that we link to, we have to manually push that update. So it's always going to be a timing thing that staff's working on. Literally this morning, we were talking about this same scenario, Commissioner.
Okay. I appreciate all your help. It was like this thing. I just want you to try to figure out why it was that way. No problem. Thank you. Proceed.
Yes, sir. And let me say thank you very much to Mr. Wagner for all he does.
Oh, yeah. I appreciate that.
I certainly couldn't explain that. Mr. Wagner, would you go to number 3, please? Our hospitalization, again, we're reporting based on our Tampa General, and again, we'll just throw in a comparison for the ACA. The trends are the same. The numbers are different. Our 7-day average daily census is 384 per Tampa General, 582 for ACA, both of those decreasing 8%. Today's census was 536. Significant, and I noted this on Monday, the prior 7 days, they've had admitted 320 while they discharged 499, again, contributing to the reduction in the total census. Bed occupancy from the Tampa General is 62%, 73% for ACA. ICU, 82% for the Tampa General, 87% for ACA. Daily average admission, 33 for the Tampa General, it's 46 for the ACA data, but again, both trends are downward. Again, I'll additionally note that our long-term care been pretty steady, about 10 a day, that now represents 20% of our admissions. And then, as we mentioned previously, our deaths have significantly increased to up to 320. We reported 328 deaths. Mr. Wagner, will you continue, please?
Sure. Kevin Wagner, Business Analyst, Healthcare Services Department. Commissioner Miller, you brought out a great point with regard to the dashboard. It is never going to be real time, and it's dependent upon FDOH updating their servers that we link to update this dashboard. So there's always going to be a lag. What's represented is a great example of that conversation. Today is 7:30, but when I ran this report and created this yesterday on the 29th, it's representing the 28th data. It is a day behind from an updating standpoint. So as Dr. Holt indicated a few minutes ago, the total cases, while here is 28,200, it's more 28,600 or 700 because of increases that have occurred. So there is that component of real time versus full complete data set. With that being said, the dashboard's designed from a knowledge standpoint of green is in a positive direction that we're wanting to go from a trajectory standpoint, and red or the salmon colors are areas of concern or areas to monitor. So on line 2 of those boxes, we see the decrease in the 7-day percent of 13% of the 7-day cases, and the 14-day 23% and the lines respectfully. So those ones are updated daily, and we have a very good tracking trend historical on down. The testing data, again, now it's a red color because the testing goal has been increased. Before it was at a very manageable area of Dr. Lockwood of 15,000 a week. Now we're at 47,000 a week, and we're not there yet, but that goal just got changed. Speaking on row 3, following Dr. Holt, what he said, this data source is right now is the TGH, data exchange. So it's great for seeing trends up or down. The red or salmon color, the ICU occupancy, that's the trending upward in the 7-day. That's a red or an area of concern at 82, almost 83%. So that's why that data is there from historical. I will say we have a 4 or 5 punch list items with the developer to continually improve this. And once they get mocked up and approved, then we'll continue to work to improve the dashboard from a communication and information standpoint. So on the cases per day, again, Dr. Holt said our 7-day average is 482, our 14-day average is 551. This is an example of the punch list item. Commissioner Overman requested a farther out view to incorporate the date of the mask ordered by Hillsborough County, the phase 1 and phase 2 opening. So this one, Commissioner Overman, it's on the punch list to be built. I think it is built, but it has to receive final approval. For a trend analysis that we are seeing a high point and a flattening on the far right-hand column. So that is the key with the every day, the 4 or 5 last days in the 400 or 500 range. So that is key. Again, we look at total age group on the top right-hand side, cases aggregate, and total cases as of the day. So this information is available publicly when they go to the dashboard. Continuing with the testing slide of this portion on the dashboard, as stated when we presented this a couple of weeks ago or a week or so ago, the testing data gets dropped in one big bucket on Monday. So this historically won't change a lot until Monday evening, Tuesday morning, again, depending upon when FDOH updates the data. So again, there's always a little trick of when the update happens versus real time. So as we see in the bottom chart on the far right-hand side, the testing positivity is 13%. Again, for that week, that's what it was. As Dr. Holt indicated, the last 4 or 5 days, we've been getting better in the 9, 10, 11% range. So again, this is a week behind, but when we look at the previous slide of daily cases, when we know our testing, the daily cases are going down, and we can basically back into and infer the positivity rates going down based upon the reports that are available. Finally, the hospitalization slide. Again, I'll speak to the bottom two. This is the TGH data source. So from a real-time standpoint, this is, again, a day behind, but it shows the trending and it shows the drop-off. Now, the TGH data source has an X number of hospitals, 10, 11, or 12, while the ACA data may have 10, 11, 12, 13, or 14. I don't know the differences. But from a trending standpoint, the value of the TGH data is we can see the trend for the most part in Hillsborough County by a significant majority of the hospitals. So we have seen that in around July 19th, July 20th, a drop-off. Now, as Dr. Holt indicated, there is some variance. Again, ACA may have a more complete set versus a real-time component, while the TGH provides us the historical standpoint. So from a health of the community standpoint, we are generally seeing, based upon this data, a flattening or a lower trajectory. And we can infer that based upon when we look at the ACA data, which again is part of the punch list conversation. And I'll stop there.
Okay, thank you. And Mr. Wagner, be ever mindful, I was not criticizing your work. Believe me, I have admired your work ever from day one. And I think I've told you that a couple of times. I was just wondering why we were having that. It's not your fault, it's how it's reported. So
Sure.
I appreciate everything you do. Thank you very much.
Thank you for your time. Thank you so much.
Mr. Commissioner Overman, you recognize.
Thank you. And thank you, Mr. Wagner, for your report and your efforts to improve the data so to help us see what's truly going on out there. I noticed between the first illustration on the dashboard regarding the ages that, you know, we're still seeing a very high prevalence between the ages of 20 to 24 and then 24 to 30. Is that what that's 52, 67? What age ranges are those? It's hard to tell from the chart.
That would be in groups of 10, basically 20 to 30, 30 to 40, 40 to 50.
Okay, so we're seeing a higher prevalence of cases in those age ranges, but in terms of hospitalizations, we're seeing majority of those that are hospitalized are in the 60 to 70 age range. Is that correct?
Yes, Commissioner.
Okay, all right. I'm just trying to, you know, the source of the illness and the impact is important. So, you know, we do have an awful lot of cases at the younger ages, but we do have a lot of folks in the older ages that are getting exposed. So it is challenging when you have multi-generational families, and that's my concern with where we're going moving forward. So thank you for clarifying that. I thought it would be important, but also thank you for your efforts in improving the data and showing the benchmarks of where we put things into place and how the numbers are shifting as a consequence of that, and how well our citizens are helping us with that effort. Thank you. I'll stop there.
Ms. Snively, you recognize. Ms. Snively?
All right, thank you. Thank you, Mr. Chair. Thank you, gentlemen, for your presentations today. Always informative, and for all the work that you're doing. I wanted to find out if a slide that Dr. Curran presented when he did his presentation last week could be ever so often added to your presentation, maybe not every Monday and Thursday, but once a week. But it was the slide that showed hospitalizations. It was a breakdown by age group. It showed all cases, new cases, hospitalizations, and death by age group. And I thought that was a very informative slide. It's almost a dashboard by age. Is there a way that we could also include that information? I think it's important to show the delineation of cases and hospitalizations and death by age to get some context to the amount of people who are being impacted, hospitalized, and unfortunately when this is a fatality for an individual. Is there a way to include that slide or that information somehow?
Dr. Holt, do you want to answer that first before I go?
I think we had said we we will happily do whatever we can. So Kevin, I think we assisted Dr. Curran in the source data. So
It looks like it came from ACA. The available data was sourced by ACA on his slide. So perhaps we could include that as well, just to give some context to those cases. And then I had a second question. I know we had talked previously today about, communicated previously about the rate per 100,000. So I just wanted to make sure I understood on your first slide, Dr. Holt, it indicates 241 per 100,000. But the math that Mr. Wagner sent was the rolling 7-day divided by the population, which is 1.4 million, multiplied by 100,000. And if I take 482, dividing it by the 1.4 million population, multiplied by 100,000, that's 34. So help me understand what the difference between those two numbers.
absolutely. Yeah, the 34 would be the daily number of rate per 100. What we're reporting is the 7. So you multiply 34 times 7, or if you divide 241 by 7, you will get the 7-day. And that's intended to sort of give you a flattening or an averaging and an overall. And it's what generally the community, public health, and nationally used to sort of standardize rather than the daily. But it's just a matter of math.
I understand. I appreciate that. And the reason I brought it up is because we had a couple of physicians come to our school board meeting recently and used the 30, actually at the time it was 35 per 100,000 as an example. And so that made me kind of think twice about the math and go back and wanting to understand that a little bit better. So I figure if local physicians are using the 34 per 100,000, I just didn't know why we were using a larger one. But I guess that's, depending on your philosophy, whatever physician has a different philosophy about it. But thank you for explaining that. I appreciate it.
Yeah, and I think I may talk about that in the next slide, or next presentation. The daily that was presented that people use is what Harvard has done to sort of group the amount of transmission going on in the community into 4 categories. And but the standard epidemiological report is always based on cases per 100,000 collectively over the 7 days. And again, it just, on a day-to-day basis, it'll change fairly rapidly, or could change fairly dramatically versus that average. So that's why we chose it.
Well, I appreciate that. And of course, we're analyzing a lot of data from local professionals like yourself and local physicians, trying to figure out what that special number, that metric is to be safe to reopen schools. And so when you hear 241 per 100,000 and you hear 35 per 100,000, you can imagine that gets a little confusing as to which number to use. The 241 obviously sounds a lot worse than the 35 per 100,000. So thank you again. We'll look forward to continuing to talk with you, Dr. Holt, as we discuss the reopening of schools. Thank you so much.
Okay, see no more further questions on that. Dr. Holt, you want to move into the update on public health capabilities for COVID-19 response?
Certainly. Mr. Wagner, would you mind assisting? Yeah. Let's go ahead and go to number 3 slide, please. So again, Ms. Snively, I think I'll try to do my best to, and I think this will explain, and I appreciate the source of confusion numbers can be. What I've outlined here is kind of and this is not necessarily a state endorsed, this is sort of locally, myself and some colleagues, kind of how to sort of progressively move down to achieve thresholds that as we move from where we are now, which is the 241 per 100, which on a 7-day average, but as you mentioned was 34, we move down from where we are, wide, high level community base, ultimately at the very far lower end to suppression. And at that rate, we're actually talking about 1 per 100,000 on a daily or 7 per weekly. My assumption is that when we reach that, even though when we reach down there, COVID-19 is going to still be with us probably for quite a while. It will eventually become part of our influenza-like illnesses, a mixture of viruses, kind of a viral stew that circulates around the community. It comprises influenza A, influenza B, RSV or respiratory syncytial virus, other types, and including other coronaviruses that are associated with the common cold. So right now, COVID-19 is dominating this influenza-like category. And so we want to do everything we can to get this back down so we can regain our pre-COVID lives and also prior to influenza season, which is going to be in the fall or so. So let's walk down through these steps. So we're currently at 241 cases per 100,000 on a for a 7-day cumulative average, which translates into 482 cases per day, which I know a lot of people kind of focus on the numbers per day average. So our first target is to get to the 175 cases per 100,000, which is that would be the 25 cases per 100,000 that is the daily average. And that's the threshold that public health leaders have set to go from the category where you're in the highest level of viral transmission into still a red, but a lower level. When we achieve, my goal is then to achieve a rate of 105, which would be 210 cases per day. But to get out of that middle layer and enter sort of or category into a yellow, we would need 70 cases per 100,000 on a 7-day, and that's the 10 per day, which it would translate into as was probably presented by the medical professionals. And at that level, that's 140 per day. That's sort of been my ultimate goal. We would then move in from a red level into kind of a yellow category, if you will. And then if we can get it down further to that 5 per 100, which is 35 per week on 100,000 or 70 a day, that's sort of the baseline goal. And then ultimately, if we can get it down to 1, we have achieved full suppression and we are in a full green category. Only way we'll achieve this is to continue with the cooperation of our public, acceptance of our of the practices, social distancing, facial covering, avoiding crowds and closed spaces, as we talked about. And, from there, we will begin to achieve, as we go down here, additional efforts of contact tracing and others to further continue this extinguishing, if you will, of isolated fire outbreaks and embers. This is not going to be a smooth or a stepwise and rapid descent, but I do expect it to happen. How long it will take is again dependent on all of us doing our part. There are going to be challenges as we go through this. Hopefully, some also advantages or advances. We certainly have the opening in schools, which we all know, but also the vaccine development. So today, from here, I want to look at the 3 core elements of our public health capabilities that we're going to need as we continue the effort to get to suppression of this virus, the testing, contact tracing, and our healthcare augmentation. Mr. Wagner, could you show the next slide, please? So our testing, we've been blessed with cooperation and really coordination between the state, county, city governments, hospital collaboratives, subject matter experts of USF, and also some volunteers from the USF colleges of medicine and nursing. The 6,750 goal per day is, as I mentioned last Monday, is an effort to ensure that everybody who needs to get tested because they're symptomatic or they've been exposed have readily available access to testing, publicly supported. We've got the Raymond James and our 7 community-based sites and our mobile units. The private sectors, hospitals, healthcare systems, particularly the urgent care large group or large group practices, including USF and some other large groups, primary care offices, and again, separate urgent care is not associated with the hospitals, really provide the bulk of our current testing. CBS is coming online, and we're starting to, again, to see some innovation with our home-based testing. I'd like to recognize that for really the first 5 months of this effort, this success locally has been achieved with local resources. Hillsborough County, the CARES has really provided a remarkable amount of direct support for the testing. Our community partners have stepped up, hospitals, Baycare, Tampa General, Advent Health, and HCA. As I mentioned, USF with their College of Medicine, College of Nursing, and certainly our community partners such as Suncoast Health Center and Tampa Family Health Centers, because we really haven't received until recently some of the state resources. Moving ahead, we need to begin looking for this transition from our public supported to our private sector. We need to begin to get more and more connected to our medical providers, our healthcare system, so our patients, our people, our public have their doctors closely involved. It's really not possible, I think, to sustain that portion of our testing much beyond December unless we get some continued support from the federal government or state government. I am hopeful for some technological advances so we can move away from some of the complicated testing that requires specialty labs, specialty machines, and we're starting to see some of those. But in the end, we must also ensure we have equal access to our uninsured minorities and hard to reach vulnerable populations as we move forward, particularly if there is this transition. Next slide. Just a quick summary, and remember that the testing is done for different purposes. For an ill or clinical, the doctors want to know, does someone who is sick, do they really have COVID-19 or not? PCR, the nasopharyngeal swabs are the gold standard for that. Contact tracing, we're looking at people who have been exposed perhaps 5 to 7 days after exposure. Most rapid way to identify if they're infected is to again do a test. PCR is what we have available. In the future, I'm hoping the antigen test, which is more rapid and easier to obtain, will be part of what we're seeing or using. Already people are choosing to screen their critical staff. Long-term care staff are the best example of that. And you'll start to see surveillance of various communities, employers will want their employees tested, USF and some other students plans for testing. When we talk about surveillance, that doesn't mean they test everyone. They'll test samples to just determine if the virus is within their community. And then lastly, we'll be using prevalence sampling of the general population with antibody widespread testing availability to determine just to what degree the COVID was impacted our community. At all times we need timely, available, and equal access. Next slide, please. So diagnostically, the 15 minutes is a standard that is available through the point of care testing, both PCR and antigen testing. Certainly we need turnaround times for the other labs within 24 to 48 hours. We need contact tracing. We want the results as quick as possible. ideally within 48 hours of the onset of symptoms or when we have notified them of an exposure. I think I've talked a little bit about some of the future, but what I'd like to see is most people may be more familiar in their offices or with their private doctor's offices to get a rapid flu test. You can get that quickly done at most medical clinics. And then even another aspect would hope testing, which would be results right there in the house, comparable to pregnancy tests. All of this will really very much help us as we move forward. Next slide, please. So here's our contact tracing continuation of this based on our testing capabilities. The current resources we have, as I mentioned previously, we had 83 internal Florida Health Department here at Hillsborough County engaged in our contact tracing. When I talk about contact tracing, it means the entirety of investigation, contacting the individuals, call centers, and a whole lot of things there. We've been augmented with 20 deployed investigators to actually talk to the cases, and 16 remote tracers. They get the information of the contacts and start making calls. We have 40 Hillsborough County CARES funded positions that we've established. 20 of them have been hired. We've got 20 of them in process of finishing their onboarding. The state has provided us funding and positions very recently for 125 state appropriations. We're working to target that recruitment with some of our partners, particularly CareerSource. The enhancements we've begun to deal with already as we've instituted a first notification. It's a combination of a call and an auto texting. These are done within 100% of the time within the 24 hours that have received the results. When we reach them, and besides leaving a message or through the auto text, we do a quick triage for prioritization of investigators. We ensure they know about the isolation, education on transmission, and that they're medically stable. And this is a program we've instituted that I'm not aware of in other counties have done. Next slide. So we also are having two focused areas. 16 staff will be dedicated to focus on both our K-12 and our universities. And we have 30 staff that are going to be focused on our long-term care facilities. Next slide, please. Contact tracing. At this stage, ideally, we'd like to get down to that lower levels if we can get down to infection rates, as we talked about, 10 cases per 100 on a daily basis, or 240 a day. It becomes most effective, and that's all about breaking the chain, identifying the cases as quickly as possible, isolating them, and reaching the contacts before they become contagious to effectively quarantine them. Case rates above 25 per day of 100,000, the benefit is less, significantly less, because of the widespread transmission. At that level, we're mitigating, which is where we are now primarily. We're trying to reduce deaths, hospitalizations, protect our essential workers from outbreaks, and looking for the high-level super spreading events. And I guess I mentioned prioritizing. Next slide, please. So our goals, we've already set our goals. Our lab results, we want back within 24 to 48 hours of symptom onset contact notification. So in other words, when we notify somebody they've been exposed and they need testing, we'd like to get those results back within that time period. we want to notify through our voicemail or testing within 24 hours all of those that we get the reported results. The 80% is because of the inaccuracy of the information we have to contact, and up to 20% is inaccurate. So we have to do extra effort to find the correct number to reach them. We will be interviewing within 24 to 48 hours of those that would get the reports of the case. 80%. We're not there at this time only because we are getting about half of those that we leave voice messages for will call us back. So we're closer to about 40% of that target right now. Our goal is to elicit an average of 10 cases per case. That's going to be a wide range. And I can't tell you the exact number at this time because of both data entry and extraction from our Merlin database. And same with, we want to notify our contacts within 24 hours of us being told who they are and their numbers, at least 80% of those. That's a metric we are established with the state, and same trouble we're having right now is data entry, so there's delayed, and tying that to the cases. So, but we expect those to be rectified, and we'll continue to monitor those as to the performance of our contact tracing efforts. Next slide. Lastly, we'll talk about our healthcare system capacity. This has been a significant success story. Staffing, our facilities have requested 515 healthcare professionals and have received a significant number of that. I can't tell you the exact number, but certainly over a couple of hundred of that have been deployed. The hospital have ICU surge plans so that they can increase capacity of their beds, again, they have the staff, to up to 150%. One of the significant factors that really has helped the hospitals, and again, recognition to the Hillsborough County leadership and the commitment to University Village is an ALF. It has 120 beds. Significantly, it has a memory unit, which is particularly challenging when COVID is in that setting. Collectively, there are 3 Agency for Healthcare ACA supported contracted SNFs. Just opened one in our county, Ybor, skilled nursing, Oak Ridge in Polk, and Carrington in Pinellas. They've collectively have 230 beds. And then, as probably you've noticed, Baycare announced St. Joseph's an expansion. Tampa General is undergoing a renovation to have a dedicated unit. And we've really had remarkable support through the state and the collaborative of the hospitals that our PPE supplies are in good shape. So that's my conclusion. That's sort of where we are, where we want to be as we continue to move forward, to move from that stepwise reduction so we can get back to this virus suppressed. And I'll stop there and invite any questions.
Dr. Holt, thank you. Thank you so very much for that in-depth presentation. Really do appreciate it. Thank you, sir. Commissioner Overman, you're recognized.
Yes, I echo that. Thank you very much. That was great data, great goals to be set. And the contact tracing and the notification has been a big issue. I know Commissioner Merman's mentioned it on several occasions. I'm still hearing testimony from people that have tested positive or gone through the testing situation that they're waiting, 15 days to get the test and then 10 days before they hear from the Department of Health. So given our numbers and the step-down benchmarks that you now have illustrated, which is really very helpful to understand where we're going and what our goals are, based on your current resources versus the goals you've got established, what level can you handle? Because we're at 241. Are we looking at current resources at 70 per 100,000, or Or do you, I mean, I'm trying to make the contact tracing goals that you've established that we're not at yet. And a correlation to where we're going to set benchmarks where we're best prepared for any kind of increase or decrease in the number of cases per day. Can you help me with that one?
I mean, we are, the resources we have and that we will have are intended to be working, to be responding from a contact tracing level at that that amount that would translate to under the 350 or 25 cases per 100,000 per day. Beyond that, we have the staff, but we're unable or would not be able to impact the viral load that's in the community. The optimal rate that the current staffing would do to actually bend the curve or would be closer to that 200 cases a day. So we've got a little ways to go to get there. The full staffing will continue to be prioritized at this rate as far as the cases we're getting, and also based on the challenges getting the cooperation and the callbacks, our current staffing is able to achieve the results we want for those that will engage us in the contact tracing efforts. So if we have more people contacting us, I think this, as we ramp up with our staffing, we will be able to maintain that effectiveness for the amount of cases that we're currently having, even if we hopefully see more and more people responding to our calls. I'll stop there.
Okay, I appreciate that. And it sounds like we're going in the right directions to get to that 105 per 100,000 level, but we're clearly not there yet. We're twice and a half that number. But to follow up with that, based on your goals that you've established, how long do you think it'll take for you to kind of hit those numbers? Obviously, you're not going to hit them with the prevalence we have now, but if we're able to continue the decline in the per day rate, do you have any idea what it would take to get to the 105 per 100,000 level?
Well, contact tracing is not going to get us down to that rate. That's where we need the community mitigation strategies to get us down. Okay. What we will be doing is continue at that level to do the mitigation, if you will, to reduce the impact of that, of the virus.
Okay, so marrying the contact tracing with say you have employees that are reporting that at their place of employment, they're seeing people work that are COVID positive. Does that go to your contact tracing team, or does the Department of Health reach out to that organization to see a cluster that may be continuing to spread?
Yeah, that's a great question. Assuming that the employee that's observing somebody not complying wouldn't know the contact tracer, they would report non-compliance to our EPI hotline, if you will. The contact tracers are required to contact those individuals on a daily basis and ask them honor code if they are complying, but as you can imagine, that won't be 100%. So if we do get reports of people that they know are positive and not complying, then what we would do is engage them more firmly, but we do not have any enforcement powers, unfortunately.
Okay, thank you very much. I appreciate your answers.
Commissioner Merman, you recognize.
Oh, no, forgot to take my hand down. Sorry.
Okay. All right. Okay, Dr. Holt, Mr. Wagner, thank you very, very much for your presentations. We appreciate it. Have a good weekend. Ms. Beck, County Attorney update.
Yes, thank you, Chairman Miller, and good afternoon, EPG board members. Christine Beck, County Attorney. Before addressing the extension of the local state of emergency, I'd like to briefly describe the two orders that were issued by Governor DeSantis late last night. The first is Order 20-179, and that order extends the ability to meet virtually without a physical quorum until September 1 of 2020. The second order he issued last night is Order 20-180, and this order suspends the mortgage foreclosure and eviction proceedings under Florida law when it arises from non-payment of a mortgage by a single-family mortgagor adversely affected by the COVID-19 emergency. That order added some additional aspects specifically relating to the single-family mortgagor, and it also defines what a COVID-19 emergency is. So those were the two most recent orders of the governor. And I'm happy to address any questions, but I'll go ahead and introduce also the item on the agenda, which is the extension of the local state of emergency. And at the appropriate time, Mr. Chair, you can entertain a motion to extend that order for an additional 7 days. Thank you.
Is there a motion?
So moved. Commissioner Merman.
That's a motion by Commissioner Merman, second by Commissioner Overman to extend the emergency orders for additional 7 days. Is there any discussion? The discussion? Seeing none, please call the roll.
Miller,
Yes.
Overman,
Yes.
Merman,
Yes.
Cronister,
Yes.
Castor,
Yes.
Ross,
Yes.
Lott,
David Burnett, Fire Chief, voting for Mayor Lott, and that's a yes.
thank you, and Snively.
Yes.
Motion carried 8-0.
Okay, anything further, Ms. Beck?
No, sir, Chair Miller.
Commissioner Overman, you have your hand up, you recognize.
Thank you. And actually, I have a question for Ms. Beck. Actually, the Florida Surgeon General gave me a birthday present on July 20. Dr. Rivkees issued an update to the public health advisory where he reinforced previous advisories and recommendations, among other things, to all individuals in Florida should wear face coverings in any setting where social distancing is not possible, both indoors and outdoors, with certain exceptions. And then secondly, although it's not inclusive, comprehensive. And lastly, that all individuals should refrain from participation in social and recreational gatherings of more than 10 people. These are the recommendations from Florida's top doctor, and it carries a great deal of weight, in my opinion. Ms. Beck, are we able to incorporate the Florida Surgeon General's recommendations in our current orders, or should we address that? And can you address where our orders actually are in alignment with the Florida Surgeon General's recommendations, recommended update?
Commissioner, those, as I understand it, those Surgeon General recommendations are fairly recent, particularly the gathering one relating to 10 or more. To the extent you wanted to direct us to add anything additional to the order, we could do so, or it could be included on our websites or however else you want to communicate that state guidance.
Just what language in our current orders might conflict with the recommendations is what I'd ask for you to bring back to us on Monday. And then we could consider whether or not we need to make any changes.
Okay, I can do that.
If that is appropriate, given our rules of making a presentation and then bringing it back and then deciding to vote on something. So But I think it's important to make sure that our public health orders actually match the, or in at least in alignment with the Florida Surgeon General's recommendations for public health safety.
Well, I certainly don't think they're in disalignment. I mean, whether they match it identically, that's what we would have to compare in a side-by-side comparison.
Excellent. Well, thank you very much for your consideration.
Okay, is there anything else we need to discuss today? Any other items we need to discuss today? Any other items we need to discuss today? Seeing no hands, everyone have a great weekend. Stay safe, and we're adjourned.
I have a question, quick.
Mr. Merman, you recognize.
If by chance the storm did take a different turn, would we have to reconvene to do a separate state of emergency? And a different state of emergency for our area? If the storm took a different turn towards us and we became under threat of having a tropical storm or first level hurricane, I guess I just wondered, would we have to, I guess it'd be a question for Ms. Beck. Ms. Beck, would we have to reconvene to do a separate state of emergency for that situation?
We have already, in anticipation of that, we've already drafted an order if that would become necessary, and I think that we would work with staff and convene, I guess, a special meeting if need be to enact that order. But yes, it would be a separate order.
Okay, thank you. That's it. Thank you.
Okay, so anything else we need to discuss today? Anything further? Anything further? Okay. Everyone have a great weekend. Stay safe, and we'll adjourn.
You too. Bye.